The talk today is a basic talk that I'd like to give to all women, because this is something that I think all women should be aware of. How common breast cancer is, what are some of the myths about breast cancer that I've heard that I want to dispel, what are your risks to develop breast cancer, something about genetics, because again that's one of the timely issues that's in the news all the time. Every time a celebrity gets diagnosed, it becomes big headlines again. What sort of screening? Very controversial. People may not realize, my medical students do not realize how controversial screening is when it comes to breast cancer. We've got very well-respected organizations arguing with each other and changing their guidelines every couple of years. So it's, and recently, both the American Cancer Society and U.S. Preventive Services Task Force have updated their guidelines just in the last few months. So I have that. We'll talk about some diagnosis, treatment for breast cancer, and a little quiz, but don't worry, nobody gets graded at the end. So basically, this is a very common cancer. 240,000 new cases of invasive breast cancer are found in women. Men are not immune. Men can develop breast cancer as well. And we have another 64,000 cases of carcinoma in situ. That's a pre-invasive cancer. It's a type of cancer that, although it's considered stage 0, it can and most likely will, given enough time, progress to an invasive cancer. Luckily, there are only about 40,000 deaths each year. We do cure most women. So the whole idea of this talk is to say how, if we are going to be stricken with this disease, how can we make sure that we're one of the 200,000 that are cured and not one of the 40,000.
Sharon?
Yes.
I was just wondering, 2016, and why the 40,000 people still die? What's wrong with those people? What's wrong with the way they're being treated? Is it totally impossible to prevent all cancer deaths in breast cancer?
Breast cancer, people die from breast cancer for one of two reasons. They're either struck with a very aggressive disease. Some of the triple negative cancers, basal-like cancers, are particularly aggressive, or they came in too late. They ignored some of the signs and symptoms. I don't like that term. I think.
I mean the patient.
Yeah. Well, it's early detection would have prevented those.
No, because 40,000.
I don't like to blame patients for their diseases.
No.
It's not negligence, but if
No,
people.
but I blame them for negligence in the mouth, or
Okay.
certainly that can.
But I am also, as a pathologist, I have a strong opinion about our treatment itself, because all our treatments are dangerous. Right? And chemo, radiation, and you don't disturb the cancer. As a surgeon, anybody will tell me that. You try to just minimize it, and we're into it. So this is, we have to look into it eventually, and we have to find some.
If you look at 40,000.
Like I said, it's very controversial, as we can see. It is the second leading cause of death in women after lung cancer. Your chance of developing breast cancer is 1 in 8. That's a lot. But your chance of dying is 1 in 35. And there are, I think, probably closer to 3 million survivors in the United States right now. So people you may not even realize, happen to be survivors that you work with, go to church with, or just see in your daily life. So it's very common. How can you, how can I prevent breast cancer? What did I do? I made a mistake, that's what I did. I turned 2 pages. I'm on the wrong page. How can I prevent breast cancer? One way is to maintain a healthy weight. Please, this is for your heart too. the worst patient I can get is a patient that has a lot of other comorbidities or other things wrong with them, because those patients don't tolerate the treatment well. It's hard to get them in and out for certain types of testing. So maintaining a healthy weight and keeping a nice heart-healthy diet is what I always recommend to breast cancer, or people that are concerned about breast cancer, not the patients with the disease, but people just even coming in for screening. Please, the excess weight is bad on a number of fronts, in particular with breast, because the more fat tissue we have, the more estrogens we produce. Especially when we're postmenopausal, when those estrogens are supposed to be nice and low, the heavier we are, we're producing more of those hormones. Those hormones are associated with an increased risk for breast cancer. So I think a heart-healthy diet and an appropriate weight for our height and age is really important. Vitamin D should be maintained at a healthy level as well. Many people are deficient in vitamin D. We're telling people to stay out of the sun, and now people are becoming less and less, have lower and lower levels of vitamin D. Every product we put on our skin now has sunscreen. So keep an eye. We may need to supplement the vitamin D, not laying in the sun, but there are other ways. Soy can be considered a carcinogen. Possibly, it may also prevent breast cancer. We don't know. That's why I have a lot of question marks. So I say anything in moderation is probably okay. So when it comes to soy, I would say, include it in your diet, but don't use that as your exclusive source of protein. Don't limit your alcohol. 1 glass of wine is certainly not going to be terrible for most people, but when women especially drinks more than 1 glass of wine, that could be considered excessive. So try to limit the amount of alcohol if you drink at all. And exercise regularly. You do not have to run a marathon. Exercise could be simply sitting up straight in your chair rather than slouching like I usually do. So, anything that keeps you your body and your muscles toned is what I consider exercise. You don't have to go to a gym to do it. And choosing to breastfeed, it's not necessarily a choice that we can make. Once our kids are grown, they probably don't want to come back and breastfeed. But if you can encourage the young people in your life, there are a lot of benefits to breastfeeding, and it's not simply to the breast itself and preventing breast cancer, that the babies are given increased immunity with the antibodies in the breast milk, and it's a lot cheaper. So formula is expensive. Just, not always a consideration until you start buying those containers of formula. I had twins 2.5 years ago, and I had to buy formula. Not a good thing. Okay, try to avoid hormone replacement therapy. I know that a lot of the symptoms of menopause are very difficult, but I discourage the use of hormone replacement therapy. There are other ways to combat the symptoms, and if it is necessary, just limit the exposure, maybe for 6 months to a year. And environmental pollution. I think we always talk a lot about that. Drinking clean water, not just water that comes from a nice glass bottle, or the different types of plastics that are bad. Try to avoid them. So here I have some myths now. A poor fitting bra can cause breast cancer. Do you know how many people come in and tell me that they have a lump because the bra didn't fit right, or they blame the bra for it? Bras do not cause cancer. I think it's important to have a good fitting bra, because it can cause some skin discoloration, can cause some changes in your breast if they're not fitting properly, and also the type of fabric. I think a nice absorptive fabric can decrease the chance of different infections, like some people have fungal infections and things at the undersurface, but that doesn't cause breast cancer. Oh, everyone tells me that they don't have breast cancer because nobody in their family has ever had breast cancer. Clearly, that's not the case, and I think people might be surprised by that, but you do not have to have a family history or a gene or something like that to develop breast cancer. That's only the case in 15 to 20% of cancer patients have that family history. That's a strong family history. So anybody, even men, but mainly women, can develop breast cancer. All lumps are breast cancer. You feel a lump, you have cancer, that's it, I'm dying. I'm just gonna go to church, I don't need to go to the doctor because I know what's going on. That's not the case. 9 out of 10 lumps, or more actually, but 9 out of 10 that we biopsy are not cancer. So it's important not to be afraid if you happen to feel something abnormal. If your mammogram is okay, and you get that letter from the radiologist that says you can come back in a year, that does not mean that you do not have breast cancer. Some cancers are not seen on mammograms. It's fairly rare, it's a good screening tool, but it's not absolute. So just because the mammogram says it's okay, if you feel or see something, then you need to take a look at that. And then, of course, if I'm diagnosed with breast cancer, I'm going to die of the disease. A lot of people think that because many years ago, people didn't talk about breast cancer. And the only time you ever heard about the person with breast cancer is because they died. So, I think that's how that myth got started, but that's certainly not true. Most people are cured, so we just need to make sure that there's no fear keeping people out of the hands of the doctor. So what is my risk? How can you decrease your risk for breast cancer? You can not change when you got your period, but being older when you started having your period is associated with a decreased risk. You cannot change when you begin menopause, but being younger is a decreased risk for breast cancer. Having more children, being younger when you have your children, and breastfeeding your children can decrease your risk for breast cancer. Nowadays, that's also very hard because most women are going into a career, and a lot of women are postponing children for that. It's very rare that a family can make it with just one salary, number one, and number two, I think women need to be independent. So women are having babies later in life. So that risk is not going to really change, but be aware of it. But get that regular exercise and maintain a healthy weight if you can. Things that will increase your risk would be that hormone replacement therapy, which I feel strongly about, trying to avoid. Having a personal history of certain non-cancerous lesions, which I'll mention later on, and the family history. Some people think that the family history has to come from the mother's side because mom has breast and I have breast, so it must be the mom's side of the family. It's either side of the family. The gene that carries the risk can be passed on from either your father or your mother, and men with the gene can develop breast cancer too. Treatments with radiation to the breast or chest, they're referring to, or I'm referring to, the mantle therapy for certain lymphomas that was given in the 50s. It's not given so often now, but if you happen to have had that or know somebody, then the patients that have had that type of radiation should be on the lookout. Exposure to DES, that also was a drug that was given, I believe it was in the 60s, so people that may have taken that. If you happen to have dense breasts on your mammogram, this is something new. This is a finding that it was always kind of sort of mentioned, but they really didn't play it up. When they wrote the report for your mammogram, the doctor would have seen the report that said breasts are heterogeneously dense, or dense breasts, and nobody would have paid a second thought to it. It turns out that it's a risk factor. It quadruples your risk for breast cancer. It's a relative risk of 4, which is very high. And now, in certain states, including New York, they're required to make a notation of the density on the breast imaging, on the mammogram. If there's a family history of people developing cancer at an early age, early means younger than 50. If there's a male breast cancer in the family, or certainly a guy who has breast cancer, if you happen to have a personal family history of ovarian cancer, because a lot of ovarian cancers are related to the genetic mutation. If you happen to be of Ashkenazi Jewish descent, there are a few particular mutations that are very common in that population. If you have a gene mutation identified in a relative, and you know that they have it, then pretty much everyone else that is in that family should just be tested for that mutation. And if you happen to be diagnosed with triple negative breast cancer, which is where the estrogen and the progesterone and the HER2 new receptors are not overexpressed or present in the specimen, those people are also at a little higher risk of being a genetic carrier, especially if it's before the age of 60. And then if there are other cancers that happen to also be associated with these mutations, such as pancreatic and colon, prostate, those are some other hereditary cancers that are associated. So if your family history includes all of those, think about at least talking to someone that can do the testing for you and to counsel you. So here's our screening controversy. Does it cause cancer? I spoke to a physician on Thursday who came into my office and was asking me about this because she didn't want to do a mammogram. She's 44. She did not want to do a mammogram because she's afraid of the squishing and that the radiation, it's no good. What else can I do? And she had a problem, actually. She was coming in with an actual problem. And I couldn't believe that someone who was a physician, who was supposed to trust the evidence-based medicine that we practice, to at least not be wooed in by some of the myths and the scares that other people are also scared by. So I was kind of surprised, and I think at the end of the day I did not convince her that she should have a mammogram, but I'm going to try to convince everybody here that they should have mammograms, because it is very important to discover cancers at early stages, and as far as I'm concerned, that's the best way to do that.
At what age is it safe to stop having them before you get them forever?
That is a very good question.
I know.
The American Cancer Society, I think, does it best. The U.S. Preventive Services Task Force tells you to stop at the age of 74. Now, plenty of people have a nice, long, healthy life beyond the age of 74. The American Cancer Society says it should be an individual decision. Depending on the health and the longevity of your patients, you might know somebody who's fairly young, but they have so many health problems that you expect probably not going to be around more than 5 years or so. You don't necessarily have to continue screening for those people, because breast cancer, if it were to develop, grows fairly slowly, and it probably would not cause any harm, during that lifespan. But if you're a healthy, vibrant 80-year-old, you want to know, because the treatment for a small little cancer is a simple procedure. You can be wide awake, cut it out, you're done. As opposed to waiting until it causes you pain and other issues if you were to let it progress. Do we know exactly how long it takes to go from that small little lesion to an invasive type of lesion? No. If we knew exactly, if we're trying, that's what all the research now is, trying to not treat every patient in the same way, but to take each patient's disease and treat it on an individual basis. Look at everything. Look at the person's own health to see, okay, I think I wanna keep this patient breast cancer free for 30 years versus I need to keep this patient breast cancer free for 10 years. You know, so you can base it on that. You can also base it on the tumor itself. Some tumors are more aggressive than others, and we have some real interesting ways that we're trying to differentiate each and every cancer individually to determine which particular cancer requires more aggressive treatment, which cancer does not require treatment at all. So, but I still believe that screening, at least getting the information, is a good first step, even if you choose not to get chemotherapy, not to get radiation therapy, or even just leave it alone, leave it there and check it again in 6 months to see if it has, you know, changed at all. I think knowing is better, personally. So, yeah.
Just wondering, you had all the risk factors
Uh-huh.
having to do with what age you have your first child
Yeah.
and you get your period. What about women who never have children?
Yeah, that's a higher risk. Yeah, so nulliparity is also associated with a higher risk. Because you have a longer lifetime exposure to estrogens. Okay, so the American Cancer Society, this was their recommendation that you probably are aware of because this has been their recommendation for in 15 years or maybe longer. And that's you get your mammogram every year at the age of 40. You should have your doctor perform a clinical breast exam once a year for you. You should, when you're younger, it may not be as important to do that clinical breast exam every year. I personally think doing a breast exam once a year should be a routine, even if you're 35. I don't see the harm in just checking to see if you feel any lumps. But this was their recommendation, and they also felt that the self-breast exams should be monthly, but they're optional. So depending on how comfortable you are doing the exam. I think doing a breast exam once a month is a good thing because only a woman knows if there's been a change to how her breasts look, feel, appear. So I would recommend doing it monthly regardless of what they say. But this is now their new guidelines as of December. They're saying don't start until the age of 45 for annual mammography. And then after 54, you can do them every other year until you are no longer in good health.
Wait, you're right.
It means, I think it really has to do with the older, the more aggressive cancers tend to show up in younger women, which is why they're saying to do the every year when you're younger. And then the lesser aggressive cancers are usually in the older women. So when you're older, you probably can check it every 2 years because not much is going to develop over that period of time, whereas if it's a more aggressive cancer or a 1 year period of time, you'd have the same kind of progression of disease. So that it makes sense, but then no longer in good health, that means go to your doctor and say, do I need to continue my mammograms? Now, if you walk in with an overnight bag filled with pills that you're taking, and not the kind that you could discontinue because you no longer need them, but that you really do need, and maybe you're on dialysis, and maybe you just had a stroke, or maybe you just, like some really debilitating things going on. If the first thing, may not be to go for your annual mammogram. But I don't know that any doctor has a crystal ball, and I think people should just go get the test done. It takes an hour. It hurts for a couple of seconds, and then you're good for a year. So I don't. But I have to. This is why there's so much controversy. The U.S. Preventive Services, you can go ahead, that they even say to don't start screening until you're 50, although you can talk to your doctor about starting earlier. Now, all of these guidelines are for women at normal risk. These are not people with genetic mutations, not people with family histories, not people who have had previous biopsies that show abnormal images, abnormal cells. But So, but this is what they're saying. They're saying don't start until you're 50. You don't start till you're 50. You can do it every other year at the age of 50, and then at 75 you don't need to do it anymore. And definitely don't do self-breast exams because people find lumps and they need biopsies. We don't want people to do that because most of the time they're not cancer. So we're causing people to have unnecessary procedures. And the clinical breast exam, basically, you know, we've studied it and we can't prove that it's effective, so you don't have to do that. So you can see where the controversy exists because these are very, very smart people with very good studies that they're quoting, and they're able to prove, in quotes, that sometimes doing these exams are not helpful. And I just personally disagree because of the way that they develop the studies. I feel some of the harms that they consider harms are not truly harms. You know, some of the harms they consider is the anxiety of having to go do the test. And then they make that equivalent to the person who had breast cancer. Like one harm is not detecting breast cancer versus detecting something and it turning out not to be breast cancer, so you had to go through unnecessary testing. I don't consider them kind of equivalent, but in the statistical analysis, they are. So, you know, it's a little frustrating for me. Although what you had brought up about people being overtreated, that is absolutely the case. I mean, there are people coming in with a tiny little nothing and getting so worried about it, having bilateral mastectomies, or going through chemotherapy for very tiny little cancers that probably would never spread. So we really do have to individualize the treatment, but the screening I don't think is really part of that. That's my opinion. So how do you do self-breast exams? I left you some cards since I am not of the persuasion that you should not be doing them. And it's very simple. Just look and feel and get to know what's normal and let your doctor know if there's any change. That's it. So, thank you. Oh, thank you. Oh no, I still have more. Do you want me to? Are we? Do you want me to finish up faster? Or we're good. Okay. So warning signs would be a painless lump or thickening or swelling that persists, nipple pain, dimpling, or any sort of discharge. And I just wanted just to describe some of the different screening tools. We have screening mammography, which is what you use for asymptomatic women, somebody with no problem to report. They're going to do 2 views, and then they may do some additional images based on what they see. The next slide. And then there are diagnostic exams, which would be a diagnostic mammography. You can do breast ultrasounds, MRIs, biopsies, and the different types of biopsy, fine needle, core needle, or different types of excisional. Some of the mammographic findings, which is why it really can't be, you can't reproduce a mammogram with another test, because what you're finding are mainly calcifications, which are only going to be seen on the mammogram. They're very, very fine, and you have to magnify it, use very, very expensive equipments. The screens that they look at the images on now, it's not film anymore. Most of the machines are digital. And you can't look at it on a regular computer. You have to have these very, very precise screens and magnification, and they have computer-aided diagnostic tools in the imaging, and you're finding very, very fine calcifications. The other thing would be asymmetries. Again, not something that can be reproduced on most other tests. Like an ultrasound, you wouldn't be able to compare the 2 sides together like you can here. And what you might find would be a density, some sort of nodule or a spiculated mass. There's something called 3D mammography. Have you guys, has anybody had it done? Okay, that's what a lot of the facilities now are upgrading their equipment, and they are offering 3D mammography. Insurance companies are not paying for it for the most part, so they're asking you to pay like an extra $50, $70. They haven't been able to prove whether or not it's better, but most of the radiologists feel it is. But we're still waiting for data to prove that it's better, and once they do that, then your insurance company will have to pay for it. So once they can prove that it works better than the standard exam. What usually happens is a lot of lesions are easier to see, so you generally don't have to call you back and do additional imaging as often. And it's much better, they say, for women with dense breasts, which is a significant risk factor. So I think 3D imaging, if you're given the option, is not a bad choice. Slightly more radiation, but because you probably don't have to have any additional imaging, I think it's even as far as the radiation goes. And radiation, just in general, for breast imaging is very small. Compared to a CAT scan or something, it's minute. So this is another picture of what breast density is. You can see the dense breast all the way at the end, and the fatty breast, which is the easiest one for detecting breast cancer. Ultrasounds are often included if they see something. Has anyone had an ultrasound? I have. They're painless. They just take a look. It's using sound waves, so you don't have to worry about radiation there. And that's used if they happen to want to distinguish something that's seen on the mammogram. It's not a substitute for mammography. And then MRI is basically used for high-risk patients, and then there are some other indications for breast MRI. And the technique is one thing that people don't necessarily like. They have to be rolled into a big tube, and it's noisy. You have to lay still for a while, but there's no pain involved. So if you ever have to do that, don't be afraid. The different kinds of cancers. This is a very general list of cancers, and it looks like a long list, but this is just in general. The most common cancer is the invasive ductal carcinoma, and within that, that's what we're talking about. Dividing into different diseases based on how aggressive these cancers are. So nobody's treated the same way as their neighbor or their friend. It should all be very individualized now. I included this slide because I wanted people to know that something that looks like an infection can actually be a cancer. And I try to, with my students, I do the same thing. I kind of overkill the inflammatory breast cancer. It's fairly rare. Only about 5% of cancers are inflammatory, but it does look like an infection and can be mistaken for an infection. And if you have darker skin, it's even harder to see because the redness, it will look more like a texture. Like it might look a little indurated, which means it's like almost swollen. The skin might look a little swollen and a little pink. But I just didn't want to leave without saying that keep an eye out for that because it's one of the things that are mistaken, and that's an emergency that needs to be taken care of right away. You don't want to stay home for a few months waiting for that to go away. We're individualizing our treatments. That is the key. And then the treatments could be surgical or radiation, which would be the local treatment right to the breast. And to bring it back to the heart disease, whole breast radiation is associated with an increase in coronary artery disease, especially if the cancer's on the left side. Especially people that were treated 10 to 15 years ago, because the radiation, the breast is sitting right on top of the heart, and if the field is not contained specifically and dedicated right to the breast and not shielded from the heart, then some of the arteries can receive some of the radiation and become fibrotic, and you can end up with coronary artery disease. A good friend of mine, 10 years after her treatment, had a heart attack. She was in her 50s because she had breast cancer. She survived. She's doing great. She's doing wonderful. But left-sided cancer, and be aware that you may, even though you don't have high cholesterol and you don't smoke and you exercise and you're skinny, you can still have a problem if you've had that radiation. And we give it for patients usually that had cancer, but still have their breast. So that's typically the sequence. but again, individualized. And reconstruction, people like to hear about the different type of reconstructive techniques, so I put a couple of cartoons. I don't have any actual pictures of them, they're all drawings, but I just wanted to let people know what the different types of surgical procedures are. You can just remove the entire breast and you're left with just a flap of skin. You can take a piece of tissue from the belly and make a reconstructed breast. It's called a tram flap, and that's using the muscle to bring the blood supply up. You can have it's similar to a tram flap. They take the same tissue and bring it up, but they don't leave the muscle intact, and then they do a little microvascular procedure to give the blood supply to the new tissue. And then you have chemotherapy and the different hormonal and targeted immunotherapies. Those also can be harmful to the heart. Chemotherapy such as adriamycin, there are different ones that are cardiotoxic, so people that have had chemotherapy should be aware of what types of drugs they were given, because some of them do have effects on the heart. And the same with that drugs, some of the immunotherapies such as Herceptin, Lapatinib, they're drugs that target the particular protein on the cancer cell, but they also can cause cardiac effects too. So just know the list of your drugs. And true or false? I cannot get breast cancer because no one in my family has ever had breast cancer. False. Okay. Next. Yay. True or false? All lumps in the breast are cancer. No. True or false? Everyone with breast cancer gets essentially the same treatment. Most people diagnosed with breast cancer eventually die from the disease. And what is for the average woman, what is her risk of developing breast cancer?
1 in 8.
Excellent. You got all the questions right.
Is that similar to the 4 questions?
They look
For
like.
cancer?
Maybe a baby.
Oh, really?
Thank you.
Are those your babies?
I'm sorry, yeah, those are mine. And that was taken about a year ago. They're a lot bigger now. Thank you.
I wanted to ask you, since you're a surgeon,
Uh-huh.
and I know surgeons' opinions are different. If you feel that the person has the genetic factor, do you recommend the, removing both breasts like Angelina Jolie?
I recommend removing both breasts if you have breast cancer and you have the genetic. Your risk of a second cancer is very high. It's like 60, 70, 80%. So if you have one cancer, definitely do both rather than just treat one. So in her case, I don't know if she had breast cancer. I think hers were prophylactic.
Yes.
So in that case, that's an individual thing. People are, it depends on how anxious the person is. If the person is anxious and scared and is dreading the day, all of her family had it, somebody just died and she wants them removed, sure. But it's not necessary unless they have cancer at that point. I think that's the best treatment.
After a certain age, if you're not supposed to have a mastectomy every year, what do you suggest? What did I say? No, I was thinking of someone that I know. The mother died of breast cancer and the daughter had both her breasts removed. That's why I said mastectomy. A mammogram. My doctor said I shouldn't have it every year now. At 80, should I have it?
You look pretty healthy to me. You look pretty healthy to me. I think people that are healthy, that feel good, that walk into a doctor's office should be getting their mammograms. The patients that I wouldn't necessarily recommend are patients maybe in a nursing home. They can't even, stand to do the mammogram.
No.
I really think that people should, because there's no harm, and the information, while you may not necessarily act on it, you may see something, say, I'll wait 6 months and see if anything happens, that's it, but at least be aware that maybe there's maybe there's a problem.
No.
But you know, they could be following these guidelines that say, oh, at 75, you don't have to do that anymore. Yes.
Would you recommend your patients that are getting mammograms to also receive a sonogram for the pickup of the cystic lesions along with the calcified lesions?
I recommend sonograms to all patients with dense breasts. So if the report says that they have increased breast density, then I'll routinely order the sonogram. And sometimes I order sonograms if they have a complaint that they're feeling pain or there's some discharge, nipple discharge, or maybe they're younger, because generally younger people do have denser breasts. So. Yeah, but I'm not just ordering sonograms because, you know, it depends. The technicians, unless they're looking for something in particular, they won't find it. Yeah, they need to look in a certain area, a certain spot.
I don't have